excellent. Thank you very much, Chris. We're moving now to the Q&A session. Chris?
Yes, I can hear you.
Okay, excellent. Thank you, Dr. Bian, for this thorough and comprehensive presentation. And on behalf of the Foresight Institute and Harvard School of Dental Medicine, I really would like to thank you for your time, your availability. There were 2,000 participants following this webinar, and I think that you have provided a lot of information. Now, we have a lot of questions here, and this Q&A will go for half an hour. So I would like to also say thank you to all the participants for their respectful participation through the chat and through the question. We apologize in advance if your questions cannot all be read. I encourage you now to direct all your questions to the Q&A session. You have it there, two options, the chat and the Q&A, and I am monitoring the questions on both sides, but if you would please send your questions to the Q&A. Dr. Bian, I will read you the questions and then I will give you the time to answer them. And I would like to start with a question about the setup of the rooms. And this seems to be a topic that is dominating the sessions. What type of special setup have you changed in your room, in your dental room, operating rooms, in terms of air pressure control or disinfection after treating patients? Can you comment on what special setups have you put in place for the operating room itself?
Thank you for the questions. And because the epidemic is coming as such a sudden, we have comprehensive and emergency departments to treat patients. And in that room, we have 8 chairs in one room. So at the beginning, we treat all our emergency care in that room, but we only have 3 doctors, sometimes 2 doctors, 2 doctors, 2 nurses, or 3 doctors, 3 nurses. In that case, all the chairs is separated as far as possible. With the window opened, we turn off our central air condition, even though that is in the winter time. And then if there is an aerosol generating procedure, we will sterilize, disinfect that region thoroughly. But if there is no aerosol generating procedure, just the checkup and some suture, remove suture, and some examination or some not the aerosol generating procedure. So we will disinfect the region. That is, I mean, in the emergency care period of time at the first month. And then starting from February 21, we have decorated a new isolated clinic, and then the pathway are separated from patient and the doctor, and they have a clean room and take on closing room, and then they have similar like infectious ward design, but it's also fresh air. We don't have an air conditioner. Of course, we don't have positive pressure or some negative pressure clinics. I'm not sure if I answered the question.
Thank you very much. Thank you very much. Now, the other question comes from Robert Horowitz. He writes, "Thank you for this outstanding and thorough presentation. Here is one of my concerns, and this question is referred to patients' intake now. Um, Triage and temperature evaluation will seem to be less relevant if 80% of transmitted cases are from asymptomatic patients who can still be infections during the few days after the contact with the virus. Do you have any suggestion how the office or clinical protocols can address that? Are you gonna moving forward? Are you using any tests? How are you screening for patients that may be infected but asymptomatic?
Oh, thank you. This is a very challenge question. This is a really huge challenge for us. See, at the beginning, at the stage of the epidemic, we don't know much about the asymptomatic virus carrier, and what we can do is to triage and task the temperature, and we have no way to identify the asymptomatic virus carrier. And then later, because all the society, the government organize all the society, and then we have some patient come, but it's not the asymptomatic carrier, but it's recovery patients who are within 14 days discharged from the hospital. And then we know that a patient, because the community volunteer will accompany this person and will tell us that this is discharged from the hospital less than 14 days. So we treat patient in the isolated clinics with the utmost protective equipment. But I cannot answer your question. We have no way to identify the asymptomatic patient virus carrier. We don't do the test before the examinations. We don't do test for all the patients.
Thank you very much. Thank you very much. This question comes from our own faculty, Dr. Ali Naseh, and he writes, where nearly 2,000 patients that you treated at your university during the emergencies, what type of procedures were they involved? And when is the university planning to go back to normal? In other words, during the emergency period, what type of procedures did you do for emergencies? And what is your plan to reopen your clinic fully?
I mean, because the signal problem, I hear that what we have what kind of emergency cases we had, and then what we're going to do to reopen our clinic. This is the question.
Correct. Yeah, correct. Yeah.
So we have online consultation for our patients, so we can inform them before if they come online. What should they do? And then some patients will come into our hospital. We have doctors to treat them. Most of them are the pulpitis, or some of them are the impacted tooth with swelling, the periodontal lesions like that. And then we do all the emergency care for them. But still, we find that some of our doctors are actually feared, and then they will try to avoid those aerosol generating procedures, and then give them treatment. So that is the emergency we can give to our patients to avoid aerosol generating procedures. We apply sometimes as ART technique with a very sharp scalpel to remove the case or to exposure the pulp, and then we give some medicine on that to relieve the pain. And to reopen the door, we are now preparing reopen. We are going to reopen our to the routine dental practice. The routine is actually the so-called routine. It's not as normal as before, but we are going to 80% of operation will resumed next week. We are going back on that way. So this is there's a lot to discuss and need a lot of time. But I think first the social condition is okay. We are for the past 1 month we have only one case is in Wuhan, and for the past 14 days there are no increase in new cases. And then we have to prepare a lot of materials to protect ourselves, and then we have regulations for our patients and the regulations for our staff, and all of our staff have tests for the nuclear acid, and we find one staff still positive and the other all. And then we have a program to train all of staff, repeatedly train, let them fully aware of the situation and fully understand the measures that protect themselves. And finally, the psychological impact on our patient and our staff is obvious. So we are also do something to relieve them. And that is also another way of preparing for back to the routine dental clinics. German?
Yeah, excellent. I had a question from the Dean of Taft University, Dr. Nadim Karimbox, and that was related to your last comment. What type of demands did you see from your staff and from your doctors, from your the personnel involved in the emergencies? Did you see any pushback in terms of being now a population at risk with this group of treating these patients? It's was your staff?
I'm sorry, there is a signal transmitting problem. Would you please repeat that again?
Sure. What type of demands or requests did you see coming from your staff? Have any staff, dentists, faculty, students requested not to work because they are in a high risk group age with existing medical conditions?
Okay. We don't have any requirement on the age or on that, but we have epidemiological study. If our staff have some symptoms related with COVID-19, or their family member have similar syndromes, we will ask this staff to stay at home, and otherwise they will. But actually, we started our spring festival. Very small number of doctor and nurse for the emergency case, and then since this is for 3 months, so the doctor nurse interns to come in. Many doctor nurse. So actually, a lot of healthy
Okay, well, I think we lost uh, Dr. Wen now. Chris, uh, is that correct?
Looks like his audio is missing. I'm trying to get him back on video here.
Okay, well, thank you, Chris. Thank you very much for all the questions. We still have 10, 15 minutes of questions, and I'm going in order and grouping them by. Okay. Excellent. All right. So we're moving to next question, and this is also a question that many participants have asked. You show some data at the beginning that other healthcare workers were more frequently infected than dentists, and then you show that I would say very encouraging graphic that during the closed down emergencies, you also have no infections among dentists. So are you prepared to say that the dental profession was already doing a good job with personal protective equipment than the other healthcare workers before this pandemic? And if that is the reason why you see a less number of infections among dentists?
I express what I see. I just said the fact that most of our dentists working the patient with a glove, with face mask, always in that way. Maybe I see few other department doctor. Sometimes I find they are not as well protected as our dentists when they're facing patient. Maybe I make a mistake. But the fact is that before January 20, we all do know there is a such epidemic. And in our hospital, in that 1 month, maybe 50,000, more than, no, 70,000 patient visits. We treat 1,000 patient times. And indeed, a few doctors and nurses are infected. It seems for me is better than the worst imagination. When we think ourselves as aerosol generating and on the mouse, so the truth is that we further have some epidemiological investigation that we have some more infected colleagues in Wuhan city, but it's not as the worst as we imagined before. So yeah. I mean our dentist is in a high risk, but we normally have a routine mask and glove may help us, maybe.
Yeah, and that's exactly the point that the audience was making in the comments, is that the fact that we, as the dental profession, may have been already doing some of the extra personal protection equipment protocols. That doesn't make the dental profession at a lesser risk. We are still at a high risk with this pandemic, correct?
Yes, thank you.
Good. Are you ready for more questions? I know it's late in China now. What time is?
It's fine. It's fine.
It's fine. All right. You are doing a great job. So I'm having a lot of questions about the current PPE protocol that you currently use. I know you mentioned that thoroughly in your presentation, but perhaps you want to give some additional comments on how your dentist providers prepare in terms of personal protective equipment.
in our emergency departments, we were using level 2 in Chinese, level 2 protection. So with a 95 face mask, with a hat, and with a gown. Inside is our normal doctor's clothes or nurse's clothes. Inside the clothes and trousers, and then when outside is with a gown, with a shoe cover. The shoe cover is as it reached the knees, as is very deep. It reached the knee, and then the gloves, of course, and then with a goggle, or sometimes the both have a shield when they are operating. So this is a second level. But if we do in the isolated clinics, and they will have a protecting clothes that is all is connected, is a whole, as a whole, clothes as a whole. So the difference is that is the clothes is different.
Thank you very much. I would like to switch for the next question, and this question comes from Natasha. For oral health staff, what protocols would you suggest on how to enter a dental office, take breaks, and what to do upon leaving work?
Oh, probably important.
So, all right. So, for oral health staff, what protocols would you suggest for personnel entering the office, taking breaks, or going for lunch and dinner? And what do you do upon leaving work? I know you mentioned also that in your presentation, but so can anybody come on regular clothes to the clinic, or we will have to change in advance?
Oh, that's a good question. We are resume to routine dental practice next week, and then before we have a small team working, so it's easier to manage, and then we may soon back maybe 50 doctor, 50 nurse, or 100 doctor, 100 nurse. So we are recently have established the route for all the department doctor. They first go into the office. There was a rule, there was a pass, is specific only for our staff. They first go to the clean area. They can change with the routine clothes, and then they change the medical clothes, like a white clothes, and then change it there. That's still clean, and then they wear the gown and all the PPE, and then entering the working place. That's what we call the contaminated area, and then they cannot go back. After they work in the before the lunch, they will go central a release area that they can take off their gown and hat and a goggle, and then step by step, and then finally they wash their hands in the central washing place. After that, they are free to go anywhere, to go home or go lunch. And if go back again, they first go entering the clean area and wearing gown, another goggle, and going into the working place.
All right, and on that line of maintenance, do you have any experience with the use of UV light for environment disinfection? Have you used any UV light procedures?
Yes, we have two kind of the air disinfection machine. One kind is the UV light that is working for 30 minutes in the lunchtime for the room. There's no people in the room, at that time, or after after work at the evening. And then also we have a kind of air disinfection machine. Is called the plasma disinfection machine that can work continuously when there is people in the room. So the two kind of air disinfection machines for light.
Yeah, thank you very much. So we're gonna do a couple of more questions, and it seems to me that among the participants, it had a lot of traction. The notion that you created a separate unit for treating COVID positive patients. And do you foresee that this is something that the investment in remodeling and making the COVID specific unit is something that you plan to keep, or is something that once we have a vaccine or a treatment, you could revert those units to regular care?
At the present, we have that isolated clinics, and actually we have 3 patients COVID-19 recovery patient come in, and also when there was a aerosol generating procedure, the doctor prefer to working in that clinics. That's also available for these doctors, and we will keep this for sometimes, maybe 1 year, maybe 2 years, if there is a vaccine available. So we will not always keep it that way until the something. Okay, so this is a temporarily set up, and we will not keep for 5 years. I don't know. I hope this academic soon end soon. Then we can give it up.
So you will be happy to renovate that area again?
Oh yes, that's true. Thank you.
I'm sure that many of the participants follow the sentiment. So I have a question from Isabel, and I kind of particularly share this question a lot. I mean, I have been going to the office to provide emergencies, and during this pandemic at Harvard School of Dental Medicine. And by the time I put all these PPE, N95 mask, glasses, goggles, and all that, it becomes very quickly very difficult to render service. So I think that we're trying to be cautious and protecting our dentists, but I think the shared sentiment from dentists who are providing services under the new guidelines, it becomes quickly an issue of comfort. Obviously, safety is first, but also, in dentistry, if you don't have good visibility, if you have good access to, see properly what you're doing, could generate another potential opening doors for other problems. Do you envision or do you support the idea of looking for alternative ways that we can protect our healthcare workers? For example, I see a lot of people wearing this full face mask with an active respirator on it. Do you think that we should be looking at new ways of protecting new ways of protect our dentists with new designs of PPE, suction that they will, control the aerosol in the area? Do you foresee that we're going to move in that direction?
I hope in the future we have some new idea or new equipment to protect our dental practice. And this academic, I think, is hurt our dental business very much. And for our hospital, almost 3 months, we only provide emergency care and with a very heavy cost on those PPE. So this is I can imagine that for private is also a very heavy cost for them to maintain their business. I hope that we have a better PPE to protect ourselves and our patients.
Excellent. And I will close with the last question. We're almost at the end of the session here. I would like to ask you a question that also is trending a lot into the questions. And it's about testing, and I think you answered that question a little bit earlier. But are there any indications that the virus that we can use any saliva test or quick testing for knowing the patient? Are you aware of any saliva testing that can be used for detecting this virus?
I hope so. So far, the virus in saliva, the source, I don't know. I have no literature indicate that the virus in the saliva is from saliva gland secretion, or they from the respiratory tract through coughing or through sneezing come out. So, but I heard some in some US they have saliva testing, and I hope that would be very helpful. Is because it's easier. I once tried the test. Is going in the deep of our throat, and it's not comfortable. And for young kids or old people may go to sampling, but for saliva it's much easier. Yes.
And do you think, and this is a personal question, do you think that the dental community should be involved in helping the testing? I mean, we are healthcare providers. We treat patients, and we are in the oral cavity. Is your university or your dentist working on somehow supporting overall the pandemic by being a point of testing while the patient is having an emergency or while the patient is coming to seek dental care?
I beg your pardon. This question is, I beg your pardon, I'm sorry.
Yeah. So do you think that this pandemic can redefine the scope of dentistry into providing detection for this virus? In other words, do you foresee dentists being or dental offices a place where patients will be tested during a dental procedure for COVID-19?
I still can't get the question. I'm sorry.
Sorry.
I don't see people have to test before they come to the come to see them. I don't see that the patient have to test.
All right. Dr. Bian, Professor Bian, I would like to really thank you very much for your honest and opening all the data. I hope your staff is safe. I hope your family is safe. And certainly you have given us a lot of thoughts for us to follow. On behalf of the Harvard School of Dental Medicine and the Foresight Institute, we would like to thank you very, very much for sharing your knowledge. And in the same way that you invited us to join you, I would like to extend that invitation back to you when it's safe to fly and move around. It will be a pleasure to have you in Boston as well. So thank you very much. Thank you all the participants. And I'm gonna give you Chris to close. I know there will be some announcement on how you can get the recording for this presentation. So thank you very much, everybody. Thank you very much, Wen, for organizing and being the mastermind of this webinar.
Thank you, gentlemen, and thank you to our participants for attending today's webinar. Due to unprecedented demand, the event reached its maximum capacity in the first 48 hours, and many of your colleagues were not able to join the event. Each of you will soon receive an email with a password-protected link to view the same video on our Vimeo page. Please feel free to share this with your colleagues. Please stay tuned for more webinars from Forsyth and the Harvard School of Dental Medicine. Thank you.